Hello and welcome. Today I'm here with Dr. Christian Lanphere to talk about Massachusetts preparedness when it comes to outbreaks of deadly diseases like Ebola. Thank you so much for joining us.
Thank you.
So we'll get right to it. Ebola and Massachusetts, how prepared are we as a state to deal with any sort of outbreak?
So I think that Massachusetts, and I think we need to go back, probably 6 or 7 or 8 years, where even after September 11th, the state, and I think along with my colleagues across the country, we've been preparing for all hazard events. So biological, chemical, radiological type, and explosive type events. So I think we've been, over the years, we've been gearing up for these types of events to unfold. Now that Ebola has really come on our shores, I think that there's a big sense of panic. But I think that we've actually come a long way.
And say, hypothetically, someone is suspected of having Ebola, contracting Ebola. Could you walk us through the procedures of what would be done as emergency and quick precautions?
Sure. So it depends on really, because flu season's coming up. So I think this is something that we really need to be mostly concerned about. For patients or people who are really concerned that if they had a recent travel to West Africa, or they may know someone who recently traveled to West Africa, and they start to develop flu-like symptoms, I would immediately get on the phone and start calling your doctor. Depending on the facility, all of the primary care doctors' offices now are all going through a triage algorithm. They're really they want to find out what exactly your symptoms are, and then if any recent travel to West Africa. If there is some type of travel, they will then alert the emergency department, and they will encourage you to go to your local emergency department. Let's say you call an ambulance, 911. All the 911 centers in Massachusetts now are all going, if you call them for an ambulance because you have flu-like symptoms, they will immediately then start asking you a series of questions to try to help them further define any recent travel or anyone you may know of who's recently traveled to West Africa. If that is the case, then they will send an ambulance and they will start preparing their personnel how to properly manage these cases. If you walk into, and you can walk into any emergency department in Massachusetts, and I'm confident that all of our emergency departments now are getting much better prepared to handle this type of event. You come into the emergency department, at least in my emergency department, how it currently works now is we will put a mask on you. The reason why we're putting a mask on you is because that's just general flu etiquette anyway. Even without Ebola, we would put a surgical mask on a patient, ask them to take a seat, and then while we start preparing the rooms. So what we would do then is we would take the patient and isolate them into a room with a door. And it doesn't, it does not need to be negative pressure. It just needs to be a room with a door. We need to remember that this is not an airborne disease, that this is droplet precautions. So we just need to make sure that they're put into an isolated room. If they come with family members or friends, we want to isolate them as well. We want to make sure that they're doing okay, that they're not potentially exposed. But we need to go down to the path first of, is this really something we should be really concerned about, or is this just general flu? So in most emergency departments around Massachusetts now are really defining who can interact with a patient. At the Cambridge Health Alliance, we're only allowing nurses and doctors. So we're not allowing any of the residents, any medical students, any physician assistants, any other ancillary personnel to come into contact with this patient. We want to dramatically reduce the exposure anyone might have with a patient who's suspected with EVD. So what we would do then is we would have our personnel get into personal protective equipment that sufficiently protects them from head to toe, no skin showing. They will go in, they will do a diagnostic screening with the patient, they'll do a recent travel history, and they'll try to manage any life-threatening events that may be occurring with that patient. If that there is a high index of suspicion with this patient, we would then transport this patient to one of our hospitals in Boston, who are much better to manage this. And as of last week, Massachusetts designated 6 hospitals in Boston to be the Ebola centers.
You mentioned isolating these patients in case they show symptoms, like even flu-like symptoms. Mm-hmm. Do we have isolation chambers in Boston or Massachusetts in general?
So, and there's been a lot in the news about these containment centers. There are no containment centers in Massachusetts. And I think we need to be very clear about what the expectations are about containment centers. They're incredibly expensive to maintain. We recently got to see the containment center at Emory, which is really set up for this type of event. And Emory is one of 4 federally designated containment centers in the United States. There's a maximum of 10 beds in those centers, but Massachusetts currently has no containment centers. We have designated units in the 6 hospitals who would empty out.
Okay, so now I have a question. I know a lot of people have the same question. You have a policy of 21 days of, in case someone shows symptoms or has flu-like symptoms or, possible scares of having Ebola. Why 21 days?
So that's a great question. The 21 day came out of guidance from the World Health Organization. And this came out because as they were evaluating all of the patients who were presenting with Ebola in West Africa, and there were 5 countries at one time that were part of this. Now we're down to 3. But what we were looking at is every patient who came down with a suspected or confirmed case of Ebola got Ebola either from day 1 to day 21. Now, most patients who would come down with Ebola would be within 5 to 7 days. Sometimes it's the average norm we've heard is also between 5 and 10 days. We've only had a few patients in West Africa who have actually come down with the disease within 21 days. That's where the 21-day mark came from.
Interesting. Now we know that Boston and Cambridge, in a whole, is a school town. There are a lot of students, international students. What could colleges and universities do to be prepared?
So we have met in Cambridge, and Boston has done this as well. We have met with the universities. Some of the universities are automatically restricting personnel from traveling to one of the 3 affected countries. Researchers and professors and students can continue to travel to other countries in the surrounding area, but there have been restrictions put into effect for those staff. Now we have infectious disease docs who do want to travel to West Africa to help with the outbreak. There, as you can imagine, there's a big need for infectious disease providers to go to help. So what we're doing is we're sending them to the CDC to get a week training where they will be going through a rigorous training with CDC personnel before deploying with one of either the military or one of the nonprofit organizations who they would link up with, and they would manage those patients. Now, when they come back to the United States, though, we would prevent them from seeing any patients for 21 days.
Now, we just spoke about the state preparedness. We'll get into clinical settings. What are smaller hospitals, clinics, and bigger hospitals doing to be prepared?
We really are discouraging any type of blood work at the community hospital level, and really we're focusing on trying to transport those patients from a community hospital into one of the Boston area hospitals, which has now been considered, again, the designated centers. We would expect them to then properly draw labs on these patients. What makes Ebola a little bit different is because of it being a virus, there are maybe rashes, or there may be cuts in the skin that you may not even be aware of. They may be micro, and the virus can then transmit. What we've done is we have decided, Cambridge Health Alliance as an organization, many other hospitals are also doing the same thing. We put all of our personnel into literally spacesuits. Now, it's not something that they're normally used to working with. I mean, they're wearing 3 pairs of gloves. Makes it already much more difficult to manage a patient, work with a patient, and do all the diagnostics that they normally would do with just 1 pair of gloves. Now you're asking them to wear 3 pairs of gloves. It makes it a little bit more difficult. The suits that they wear. We are currently putting all of our personnel into biological suits. They talk about Tyvek suits, but we want it to be an impervious suit. So that way, if in the off chance that they get any type of bodily fluid, whether it is vomit, it's diarrhea, any blood, any secretions, any of that stuff, if it gets onto the suit, they will still be well protected so that it will not penetrate through.
Talking about travel bans, a few weeks ago, Logan Airport wasn't one of the few that was made to do rigorous screenings. Why so? So, one thing we need to care about Logan Airport is that Logan International Airport sees a lot of international passengers. And for as long, I've been doing this for 20 years. And for as long as I can remember, there's a quarantine station at Logan Airport.
I think a lot of people don't realize that. But passengers who come from various parts of the world, there's 4 or 5 or 6 passengers who were feeling fine on the airplane, but by the time they got to Boston, they weren't feeling so well. We have a quarantine station. It's the CDC quarantine station that the Boston Public Health Commission currently runs. And we would then have those passengers transported to that quarantine station to be evaluated.
Talking about that, so we have health workers returning from West Africa and performing their duties, and New York, New Jersey, and Illinois have imposed very strict quarantine rules. What is your take on that, and also the visa bans that Australia and Canada have currently imposed, that people coming from Ebola-affected countries are not allowed, not given visas?
So I think that's counterproductive. I'm not sure how effective it is, because when you are departing from one of the 3 countries in Africa, now some of the countries, New Guinea is one of them, where they are actually requiring, they're quarantining them locally there. So they're making it more difficult for them to get out. They want to isolate them there, whereas Liberia is asking for any direct contact. Now, in the case in Texas, the patient who lost his life, unfortunately, did not accurately inform Liberian authorities that he had contact with family members, and he also participated in burial rites for victims who succumbed to the disease. So we're taking it's an integrity. We're taking people's word that they are. So I'm not sure how effective that actually is. I think the important thing is that not to quickly rush too much about information. So I think Texas was a great example of a situation where there's a lot more misinformation that came out of Texas than accurate information. So by providing any of the guidance that the State Department of Public Health puts out, that the Centers for Disease Control and Prevention puts out, I think those guidance that they're really geared for the public. With this week alone, the Mass Department of Public Health has put out guidance now for businesses. They've put out guidance for child care centers. So they're starting to put out a lot more information about what people can do. And I think all of that information is really readily available at the 6th grade reading level. So most people can understand it. It's put into many different languages. So for citizens who actually have concerns about they're not unable to read it, there is a mechanism now to get that information. People simply sitting on a subway system, I think, for a good example, or on a bus, because we are such a transient community. Right. You're not going to get Ebola from sitting next to someone on a train. And I think, this is the term I've heard a lot lately is, this is now the AIDS epidemic all over again. The way people are being treated was the same way that patients who look like that they may have had AIDS were treated back in the 80s. And so we want to make sure that we really are not, that we're not targeting certain individuals who may look like they're African. So we want to make sure that regardless of where you may come from, we want to make sure that people are not being singled out and are being treated like someone having Ebola when they've never even visited. They've never even left the United States. We want to make sure that everyone's being given the same opportunities. But I think that you will see a lot more people are wearing masks. They're wearing masks. And I think that the Chinese community is because China does this. Even folks from South Korea do this. It's normal in their culture for them when they don't feel well to wear a mask. Now, does that mean they have Ebola? No, of course not. They may not even be sick, but they may not be feeling well, so in their culture, they put on a mask. When you go into a hospital, it is normal etiquette now, as part of our flu preparedness and prevention, is to ask patients who are exposed, who are not feeling well, to wear a mask.
This has been very, very helpful. We would like to thank Dr. Lanphere for sharing his insights with us about our state's preparedness to confront outbreaks of diseases. We hope that you have found our conversation to be helpful in providing perspective on this important issue. For Arlington Public News, I'm Akriti Jagmohan. Thanks for joining us.